Welcome back, everyone. I know it was a short break, but we're hoping to get started again to just stay on schedule. My name is Lisa Axel. I'm a genetic counselor. I may have met with some of you over the years. So session one is going to be about cancer risk reduction. So we are going to have Dr. Swati Patel come back up. We're going to have Dr. Aldridge, and then also our dietitian, Patty, is going to come share some information with you. So to start us off, I am happy to welcome back Dr. Patel. As you all know, or most of you know, she's a gastroenterologist here at the University of Colorado, and she will be talking today about the importance of colonoscopy quality.
Thank you, Lisa. I know that was a short break. I was asked to make one announcement. It sounds like the front doors are intermittently locking themselves. So if you go outside or take a break, just make sure you either get the cell phone number of somebody up front who can let you back in, or a family member to let you back in case they lock. So it has nothing to do with colonoscopy quality, but perhaps event planning. But nonetheless, what we'll spend the next 20 minutes or so talking about is really a procedure that most people in the room have not only had once, but many, many, many times over. Honestly, I wish we had more time. When we designed this session, I thought I could give a broad talk about everything cool we do in GI to decrease cancer risk, the advances in what we can do to decrease upper intestinal cancer risk, like Dr. Lynch mentioned, these upper endoscopies that we do with your colonoscopies, what we're looking for, how we can visualize much deeper into the small bowel with a variety of different really incredible technologies, and really a lot of recent promising data on a cancer that in the past has really been something that has been a bit of a frustration, pancreatic cancer surveillance. We now have emerging data that among those with high risk, we actually are seeing really promising outcomes in screening and surveillance. So if any of these topics are of interest to you, please let us know. Perhaps we can include them in future symposia. But for today, we'll try to address three, I think, fundamentally important questions when we think about colonoscopy. What are we actually trying to achieve when we do colonoscopy in our Lynch syndrome patients? Why is quality important? Is it not like any other test where whether you get a scan here or a scan in a different city, shouldn't it be the same? And based on what we talk about, how can we ensure that you, your family, are getting a top-notch colonoscopy? As Dr. Lynch really elegantly explained, those with Lynch syndrome essentially have this inability to fix mistakes. So every time a cell divides in every single organ of our body, which happens millions and millions of times, it has to duplicate that genetic code. So mistakes are kind of bound to happen, and these mismatch repair genes are designed to find and correct those mistakes so that then that cell has normal DNA code. In those that have absence of this mismatch repair function, if it's not working, well, then the mistake can't be fixed. And in that cell, whether it's in the colon, whether it's in the uterus or the skin, that mistake gets incorporated into the genetic code of that cell. You can imagine that if the thing that's supposed to fix mistakes, the spell checker, is not working, if that happens and mistakes start to build up in important genes, the genes that we know are responsible for how cells move, how they divide, how they grow, how they migrate, well, then you can imagine that cells start to grow abnormally, and their next generation of cells grow abnormally and predispose to tumor and cancer formation. And if these mistakes can't be fixed, essentially, this can cause a snowball effect where things can very, very rapidly develop. And as Dr. Lynch mentioned, cancers in Lynch syndrome can develop much more rapidly than in the general population. So when we're thinking about colon cancer, for the most part in the general population, we think about this progression from normal tissue that can sometimes grow into a small precancer polyp that over time can progress and grow into a cancer. For those without Lynch syndrome, this question was just asked to me as I was coming up to the podium. How long does that take in the general population? Well, usually around 8 to 15 years, if it's going to happen at all. So that's why your neighbor, if their colonoscopy is normal, doesn't have to come back for 10 years. In Lynch syndrome, however, this is an accelerated process wherein sometimes we can see cancers develop as quickly as a year after a colonoscopy. So Dr. Lynch reviewed our guidelines, what the National Comprehensive Cancer recommends for our Lynch syndrome patients, and based on the different risks that we observe on the gene that's effective, we know that those with MLH1, MSH2, EpCAM, which is a gene that sits right in front of MSH2 and kind of causes MSH2 Lynch, those patients develop cancer at earlier ages and have a higher lifetime risk of cancer. So the National Comprehensive Cancer Network recommends starting colonoscopy between the ages of 20 and 25 and repeating it every 1 to 2 years. But based on the data that Dr. Lynch showed us, we have observed that it appears that MSH6 and PMS2 patients have a lower risk and may develop cancer actually at later ages. And so more recently, the NCCN has suggested that we could potentially start colonoscopy later, between 30 and 35. Now that asterisk is, or 2 to 5 years earlier than the earliest cancer diagnosis in the family. So that family history is important to know whether we should start earlier. And that maybe we can relax that interval to 1 to 3 years. So really one of the most satisfying parts of my job, outside of seeing you all in the clinic and talking with you all, is what I do in the endoscopy lab. And that is hunt and find these polyps and take them out before they have a chance to grow and turn into cancer. So what do we do when we do colonoscopy? Many of you have had this procedure. We essentially insert a long flexible scope that has a light source and a camera at the tip of it, a channel where we can irrigate fluid into the colon, suction fluid out of the colon, and we advance this scope through the anus, through what we call the sigmoid, descending transverse, ascending colon, all the way to the cecum, which is essentially the anatomic term for the beginning of the colon. We also often recommend inserting the scope into the last part of the small intestine, the terminal ileum as well. So when we do colonoscopy, what is it that we're actually looking for? Well, we're looking for polyps, right? But like most things in life, and certainly in medicine, it's not as simple. Not all polyps are the same. The most commonly found polyps are adenomatous polyps. And many of you, if you look at your pathology reports, see these terms. But there's even subtypes of those adenomatous polyps. There's tubular adenomas, tubulovillous adenomas, villous adenomas. And then the other commonly encountered polyps that we see during colonoscopy are serrated polyps. Of those, there's hyperplastic polyps, sessile serrated polyps or adenomas, and traditional serrated adenomas. These are really just subtypes based on what they look like under the microscope and sort of how they progress from normal tissue to precancer or possible polyp. But the reality is not all polyps are precancerous. So how do we wade through all of this? Well, typically hyperplastic polyps are these small polyps that really are now quite well established to not confer increased risk of growing or turning into cancer over time. On the other hand, tubular adenomas, sessile serrated polyps or adenomas, they do have that potential to advance and grow and are considered intermediate risk polyps. Whereas tubulovillous adenomas, villous adenomas, and traditional serrated adenomas are the types of polyps that we actually consider higher risk. The ones that there's changes under the microscope that suggest that they really are on their way to potentially progressing and turning into cancer. Now, if you have a tubular adenoma or sessile serrated lesion with either high-grade dysplasia in a tubular adenoma or any dysplasia in a sessile serrated lesion, dysplasia is just a term we use for precancer. So high-grade precancer changes in tubular adenomas or any precancer changes in a sessile serrated polyp actually put those types of polyps in a high-risk category as well. So we find these polyps all over the colon. The hyperplastic polyps tend to occur mostly in what we call the distal colon or the sigmoid colon, descending colon, in the rectum. Tubular adenomas can essentially occur anywhere. And the sessile serrated lesions typically occur in the proximal colon or the ascending colon, the cecum, sometimes the transverse colon. And then these traditional serrated adenomas tend to occur in the rectum. So the answer to this question is pretty easy. What do we do when we find polyps? Well, obviously we want to take them out, right? So whether it's a small polyp like the one here on the left, or this monstrous polyp that's really extending all the way through, taking up more than 3/4 of the circumference of the colon here on the right, our goal is to take these polyps out safely and completely. And particularly in Lynch syndrome, no polyp is too small to be worried about. We need to make sure that every polyp we remove is removed completely, because any residual tissue we do not want to leave in place and allow for the possibility of it to grow, progress, and advance to cancer under our noses. So it's critically important that we completely remove these polyps, and there's a specific skill set. I see some jaws dropped in the back there, and I hope everyone's breakfast has settled a little bit. But it's critically important. And, there's, I'm sure, lots of questions, and we can talk about polypectomy technique. But whether it's the tiny polyp on the left, which takes 10 to 15 seconds for us to remove, or this more advanced endoscopic mucosal resection, it's really, really important that you're in the hands of a colonoscopist who knows how to remove these safely and completely. So how well does colonoscopy work? Well, Dr. Lynch presented some provocative data from the Europeans that is really observational data. What that means is that in all these countries that he referred to, Germany, Netherlands, in Finland, essentially they looked at the patients that they had with confirmed Lynch syndrome and whether they were getting cancer or not getting cancer and at what rates. And it's a powerful study because it has thousands of patients in it, long-term follow-up. But what's missing is that we don't know how many of those patients actually got colonoscopy, exactly what interval they were getting it at. We kind of know what interval the countries recommend just based on guidelines, but guess what? Not all of us follow the guidelines. Not all of us can get colonoscopies at those frequencies, and really not much detail on the procedures. And we'll talk about why that's really, really important. But the early data on colonoscopy and Lynch syndrome suggested that actually it helps. Finding these polyps, removing them, early studies suggest that it could decrease your chance of getting colon cancer by 87% and dying from colon cancer by 94%. That's pretty good. Maybe a little bit skeptical with more recent data from the Europeans, though we have question marks about kind of the details of adherence to colonoscopy and quality of colonoscopy. But for those of you getting colonoscopy every year, why isn't this number 100%? If you're putting yourself through the bowel prep, taking a day off of life, family, work to get to your procedure, you'd think that that would be protective to go through all of that every year of removing these polyps. So generally speaking, right, if a cancer happens after we do a colonoscopy, it's probably one of three things. As Dr. Lynch mentioned, it's certainly possible, and probably the vast majority of the times, something was not seen on the first colonoscopy, whether it's a precancer polyp like I showed you, or even a cancer. It's also possible that we found the polyp and we did our best to take it out, but didn't get all of it. And then this really kind of area of kind of fascinating research and understanding of the biology of Lynch and probably how things just grow faster in Lynch syndrome than the general population, so this rapid growth. So let's talk through these a little bit. As an endoscopist, when we are driving our scope through the colon, for us to really try to decrease the chance of missing things, I tried to really frame everything that we do in sort of two fundamental concepts. One is looking at things. So opening the hood, really trying to expand the colon, clean and wash away things, and make sure we're seeing and exposing as much of the colon tissue as possible. The colon is this dynamic organ with dips, dives, folds, and if we don't fully expand that and visualize it, we could certainly not even open the area that could have a problem. The other piece is actually recognizing the problem. So the hood's open, but what's actually causing the issue? And I think a lot of the things that we do in colonoscopy to try to optimize quality really are aimed at sort of improving these two things, exposing the tissue, and then once the tissue is exposed, really recognizing those even subtle things that could be abnormal versus normal tissue. So we'll talk about the things that we do right now to really optimize these things and what we understand about how they're related to cancer risk and Lynch syndrome. And then some of the new kids on the block that maybe your doctors are using or maybe around the corner. So this seems pretty intuitive, right? The whole point of the colonoscopy is to advance the scope all the way to the cecum. Obviously, if you don't get to the cecum and don't see parts of the colon, you have a really high risk of missing things if you don't even get there. So you'd think that that's really the lowest kind of bar or hanging fruit. There was a study published out of Spain from multiple centers across the country that were Lynch syndrome centers taking care of Lynch syndrome patients. And they collected data on about 800 plus Lynch syndrome patients who got colonoscopies. And in their study, they actually found that in real practice, that over 10% of the procedures done as part of this study were not complete to cecum. So that's pretty humbling. I think it's not really the standard that we want to adhere to. And then when they looked at how a completeness of an exam was associated with things that we're interested in, whether patients get polyps on follow-up, whether they get cancer on follow-up, in fact, protection is on the right there, but those who had a complete exam were much more likely to be protected from having a risk of colon cancer in the future than those who did not have a complete exam. This is intuitive, but this study really demonstrated this. Okay, now I hope your stomachs are really settled. The bowel prep is really one of the most challenging parts of completing the procedure. It is really hard to tolerate that purgative, but it is so critically important. And you don't have to be a trained endoscopist to know that if you come in with a bowel prep on the left, there is a really strong chance that we're going to miss something very, very important if it's there. But honestly, even the picture in the middle there's a lot of debris, there's a lot of adherent material, and as much as time as we can spend with irrigating and washing, it's absolutely accepted, no matter how much we do that, it's going to be a much more challenging exam than, for instance, the bowel preparation on the right, where the bowel prep is pristine and we just focus our efforts on examining. A lot of questions that I get asked and our GI nurses get asked, well, there's a million bowel preps out there, and each year it seems like you guys change my prescription. What's the best one? Which one should I be doing? And just tell me which one to do and I'll do it. Well, it's overwhelming because the bowel preps kind of change over time. And, I think the way to kind of understand how to sort of decide depends on a few things, but we kind of divide them into what we call high volume preps. So these are those old school kind of 4 liter plus kind of large volume salty preps. And then these newer, lower volume preps that many of you use, some of them over the counter, many of them prescription, that are 2 liters, sometimes less, sometimes those with just pills. What's key is that no matter what prep you do what's called a split dose prep. And that is take half of it the night before and then wake up as early as you possibly can or set an alarm to complete the second half the morning of the procedure. Why? You haven't been eating anything, you're not making anything. Well, the body continues to sort of make waste product. And so that final second flush is what gives us this beautiful, pristine prep, especially in the cecum and the ascending colon, that's really now the standard of care. So that piece of torture, waking up to do the second half, is because of this. So what's the best prep if we just kind of compare them side by side? The reality is between the high volume and low volume preps, they both achieve about the same quality of bowel preparation. As you would expect, the lower volume preps, there's a little bit better adherence in our patients. The polyp detection rates are about the same. But what's really important to note is that, and as we would expect, the low volume preps are just so much easier to tolerate. And our patients, this last piece is super important for us, right? Because you've got to be willing to repeat, because your recommendation will be come back in 1 to 2 years. It's not, okay, I'm going to kick this can down the road for future Patel in 10 years. Like, this is going to be a 1-year issue. So that willingness to repeat is incredibly important. So I think the bottom line is, putting all those, commercial products aside, the best prep is the one that you can tolerate. And by tolerate, if you have side effects or symptoms, or the volume is something of issue to you, the taste, please talk with your provider. There's lots of ways we can work around that. And many of you can actually coach a newbie who's getting their colonoscopy for the first time, because you've already found all the tips and tricks. And the key is that we want to achieve any prep, no matter what it is, with the right results. And so what do we know what that looks like? Well, as gruesome as this is, if you see this or this, you got to keep going. And maybe that keep going is additional Miralax that you have at home, or milk of magnesia. And what we're really looking for is this, where you can see the bottom of the toilet bowl, kind of diluted Mountain Dew. This is really, really important because not only is it associated with a easier to tolerate procedure, but it's also protective of developing colon cancer in the future. Inspection technique, this is something that we talk to our trainees about all the time. And so your doc really, if they do a good job of flattening down the folds, opening up the colon, cleansing and washing away debris, those docs have a higher chance of finding polyps than docs who have low scores on some of those metrics. What about actually recognizing polyps? So we've talked about what you can do to really kind of visualize as much of the mucosa as possible, but what about actually finding the abnormality when it's right in front of you? You'd think it'd be easy, right? You Google a polyp and it looks like a big mushroom in the colon, but the reality is actually a lot more subtle. Sometimes these polyps can be really flat. Maybe the only kind of clue is that they're a slightly different color or different contour. And they can be really large and still quite subtle. And so, as you can see, for the untrained eye, they can be very difficult to detect. Do you see the polyp here? We can use lights to filter through the colonoscope to help delineate it a little bit better. And sure enough, that's a huge polyp in one of our Lynch syndrome patients. What about here? Do you see the polyp here? What about now? Right, there's the polyp. You can see how this would be incredibly challenging to detect without training. And the reality is training does improve polyp detection. So really training our budding endoscopists to learn how to recognize these lesions is really important. High definition equipment. So what does this even mean? Well, if you look at the picture on the left, you see kind of the resolution of that image versus the one on the right. And the kind of most important analogy I can give you is just think about the technology in your cell phone and how it's evolved over the last 15 years. I'm an Android person, so I don't know if I chose the correct image here, but old school generation iPhone versus the photos that you can take with your iPhone now. And that's really exactly kind of the advances that we've seen in our magnification, our resolution. And so high definition equipment is critically important if we're talking about these super, super subtle polyps. And this same Spanish study showed that, again, in a somewhat contemporary practice, only 12% of these procedures were done with high definition equipment in Spain, and that high definition equipment, again, was protective of potentially developing colon cancer down the line. So chromoendoscopy, we'll just spend a moment on this because many of you have been subjected to this blue dye that you poop out for a couple days after your procedure. So chromoendoscopy is this chemical substance that we can spray into the colon. Then the concept was that it helps provide contrast to kind of help make it easier to see normal versus abnormal tissue. And there were a lot of early studies that were promising. And so we would do this all the time and, spray this dye throughout the colon. But more recent studies, especially studies done with this high definition equipment, really have not shown much benefit. And so I think, this was really then summarized where they took data from all of these studies, and in procedures that were done with high definition equipment, we now sort of practice by using this electronic chromoendoscopy, or with a touch of the button, if we need to, we can filter light to provide that contrast, but the spray dye we don't routinely use anymore. So now we'll just spend the last minute or so talking about some of the new kids on the block. You might see other tools that are used in the endoscopy lab to help improve exposure of the mucosa. There's all sorts of attachment devices that we sometimes use to kind of flatten out the folds or open up the lumen of the colon, balloons and things like that, even cameras that have ports on the side to get more of a 180-degree view of the colon. And then, of course, artificial intelligence. We've known for a long time that the more eyes you have trained on that monitor in the endoscopy lab, the better you're going to be at finding polyps. And there have been study after study showing that if you have a GI fellow working with you, improved polyp detection and adenoma detection. If you have a nurse that has their eyes trained on the screen, improved polyp detection. So it definitely is of no surprise that if you are able to have a set of eyes that is not distracted by the music that's playing in the endoscopy room or grabbing the tool that you need for your next procedure or asking you a question, that if you have some way for artificial intelligence to essentially be that eye for you, these are now technologies that are on the market and that many practices are using, including us here at the University of Colorado and at the VA, that put these bounding boxes in real time while we do colonoscopy to help us find these polyps. And perhaps these are polyps that we would have found anyways, but anything we can do to push the quality of our procedure, we will do for our Lynch syndrome patients. It has to be in hands that can interpret it, okay? That looks scary. That's a lot of polyps. Well, at least that's what AI thinks. But in fact, that's just normal small intestine tissue. So sometimes you got to turn the box off depending on where you are. So just the last moment on incomplete resection. Like I showed you in those videos, polyp removal technique can be quite involved. And you really want to be in hands of somebody who does this at a high volume and knows the limits of their practice and when they maybe ought to refer to a colleague who has expertise in complex polyp removal. This was a pretty humbling study that was published where the doctors essentially took the polyp out as far as they thought was complete. And then they just biopsied the periphery of what they thought was normal tissue. In those biopsies of what they thought was normal tissue, 10% of polyps had precancer polyp under the microscope. So 10% incomplete resection rate. When they looked at kind of the medium-sized polyps 15 to 20 millimeters, 23% had residual precancer tissue in the peripheral biopsies. And then when we think about those sessile serrated polyps, the really subtle ones, the flat ones, that incomplete resection rate was almost over 30%. So this is a real issue. So I think when we think about these guidelines that our bodies sort of recommend and that we want to disseminate in the community, the key is not just the letter of what's written here, but to ensure that we're offering the highest quality procedure. And I think the bare minimum is that the procedure is complete to the cecum and terminal ileum, that there's an adequate but ideally pristine bowel preparation, that we're all using the latest high definition equipment. And certainly there are lots of cool bells and whistles, but that you really need to have a meticulous endoscopist. And sometimes that's hard to figure out. You can ask whether you use high definition equipment, or you can see on your report whether it was complete to cecum. But how do you know if your doc is in tune to what Lynch syndrome patients can develop and what to look out for? Well, I think these are some practical questions that you can ask your doctor, and there's no right or wrong answer to these questions, but their response will likely clue you in to their kind of familiarity with and openness to discussing colonoscopy quality. So adenoma detection rate is sort of a quality metric that we all measure among endoscopists. It's not specific to Lynch syndrome, but it's just a marker of quality. And if you have an endoscopist who says, wow, what a keen question, sit down, let's talk about this, and I'll tell you my ADR compared to my practice and my patient population, I'm so glad that you're bringing this up, that can be a completely different response than if you get some resistance. And similarly, it's helpful to understand, well, doc, if you find a really, really big polyp in my 30-minute procedure that I have scheduled, what's our plan? You know, and just helping you understand, okay, well, I actually like the idea of you marking it, and then we talk about it, and maybe you connect me with one of your colleagues who specializes in complex polyp resection. So we've talked about sort of these quality issues in colonoscopy, but we all know that Lynch syndrome biology is unique, and Dr. Lynch reviewed this. We'll hear about it sort of referred to throughout the day, but a large part of what we understand about Lynch syndrome biology is that things can go rapidly and sometimes things can progress possibly through non-polyp pathways. And so it's really, really exciting that in addition to colonoscopy, we've got lots of other things to help mitigate risk. Aspirin, Dr. Lynch spoke about. Resistant starch, we'll hear about a little bit later this morning. And then really incredibly innovative research that's being done, including this vaccine trial, which we are participating in. So high quality colonoscopy is the cornerstone for risk reduction in colon cancer among Lynch syndrome patients. And although the bells and whistles really up our game, I don't think they'll replace a meticulous endoscopist, at least not yet, and hopefully not anytime soon, but I would be humbled to be replaced. Thank you very much.